Select Committee. We're live in the Palace of Westminster in the House of Commons, and this morning is our first evidence session into our new inquiry into assisted dying, assisted suicide. It is a subject that obviously is incredibly sensitive and affects us all, which is how we die. Obviously, some people feel incredibly strongly about there being the need for a change in the law. Some people feel incredibly strongly that there shouldn't be a change in the law, and many people are obviously well aware that there is a debate raging on the subject and have not picked a position on this and may never do so. Our purpose is to look at all of the issues and the evidence, and to do so, as we always try to do, in the most sensitive way as we can possibly. A call for evidence on this inquiry was launched at the start of December to collect evidence of domestic and international views on the subject, and just briefly set out for those watching, the terms of reference were things ranging from to what extent people in England and Wales have access to good palliative care, how that can be improved, and would such improvements negate some of the arguments for a change in the law, what we can learn from evidence in countries where the law has already been changed, what are the professional and ethical considerations involved in allowing physicians to assist someone to end their life. And there are a number of other terms of reference, all of which are available on our website. In today's session, it's the first oral evidence session for our inquiry. We're going to hear from 4 peers who've been involved in work on this topic over many years, including those who've attempted to introduce legislation into the House of Lords to change the law. And then on our second panel, after we'll take a very short break, we'll hear from the current evidence base with academics with expertise in the fields of palliative care, end-of-life care, and the experience of healthcare professionals involved in medically assisted deaths. So let me introduce panel 1, which is here before us. We have Baroness Finlay of Llandaff, we have Lord Falconer of Thoroton, we have Baroness Meacher, and we have Baroness Hollins. Thank you so much for giving up your time and speaking to us at the very start of what is an incredibly high-profile inquiry. We're aware that there is huge public interest in this. The amount of evidence that we received, the amount of replies to our survey has surpassed any expectations, and my clerks are thrilled with the tens of thousands of replies that we received. But I would just like to place on record my thanks to them, because it has been a huge volume of work that has come into them. Before I open up the floor to my colleagues, I just wanted to ask each of you to, not discussing the law, not discussing the procedures. I just wanted to ask each of you to speak from the heart and to tell us why you care. I said at the start that some people care deeply on both sides of this. Why do you care so much? Maybe if I could start with former Lord Chancellor, Lord Falconer. Why do you care so much, sir?
Well, I'm like everybody else in this issue on policy, which is I myself have had personal involvement in somebody dying who a point is reached where it turned out that there were weeks to go, but there was nothing left except an increasing focus for the person who was dying on their inward suffering, where death was absolutely inevitable, and where it was absolutely clear that her assisting herself to die would have been unquestionably the best course, but that was not possible. So a long period went on where there was, how can I judge this, quite bad suffering for her and quite bad suffering for those who loved her. After that experience, which is what started my involvement, I then got interested in the issue for obvious reasons. I wondered whether or not palliative care being better for everybody, because it should be better for everybody, would make the difference. As it happened, the person who I've just referred to was in the health service, and therefore quite high quality care was given. And there desperately needs to be an improvement in palliative care, but it's absolutely clear that improving palliative care will not resolve the needs of some people to end their life in the context of a terminal illness earlier. There's widespread sympathy for the position that I adopt. Indeed, the law has turned itself on its head, with the law being it's a crime to assist somebody to commit suicide, but the law will not be enforced by the DPP because everybody accepts it's a nonsense of a law. There needs to be safeguards. As it happens, the assisted dying proposal is now the most, if it became law, would be the most safeguarded route to an earlier death, because it's more safeguarded than withdrawing your own treatment, the hospital deciding you're not going to be treated. If you're under the care of the Court of Protection and the doctors in your family agree, then you won't get then you can have that stopped without any intervention. So it's the most safeguarded. Where have we got to now? It's such a mess, the law now. We will allow people to go to Switzerland. We will allow people to be helped to go to Switzerland. We'll investigate their loved ones when they come back, which is a hellish experience. The law is such a mess, and I don't think I've met anybody who doesn't think that. And the law itself recognises that. I think it's time for a change.
Thank you very much. Baroness Hollins, if I come to you next, why did you want to come and speak today? Why do you care so passionately about this subject?
As a doctor, as a psychiatrist, I am very, very worried about, and as a legislator, I'm very worried about the unintended consequences. And I think no country in the world has succeeded in creating a law which actually protects people who find themselves in vulnerable situations. So that is my main reason. And I think that one of our real difficulties, it's like 5% of the world currently has access to physician-assisted suicide. That's all. It's a minority, and it's not proven to be safe, essentially. And attempts in previous private members' bills to make it safer have not been well received by the proponents of the legislation. My work on death education, I've been an academic psychiatrist for 40 years, but my work teaching medical students, for example, and community staff working in mental health services, all the time we found fear about talking about death. We don't have adequate death education in our society. It is driven by fear. And this is one of the big reasons. For me, I would like to see a much more accepting conversation about death, which is an acceptance that this is something that is going to happen to all of us, and it's a normal process. And the more we talk about it, the more there is a possibility that people will get the help they need when they're dying, so that they can die in comfort, with family and friends around them, without all the anxiety that goes around assisted suicide. I've been teaching more recently through a charity that I set up, Books Beyond Words, within schools, which has been fabulous, to begin to talk to children who've been bereaved. Parents that die, I think a parent dies every 20 minutes or something in the United Kingdom. There is something like every class will have at least one child who's been bereaved of a parent. And yet, teachers are not comfortable talking about death. And we've been trying to introduce ways to do that. So that's really, really important. As a clinician, and as a researcher, just seeing how the people that I'm particularly concerned about, people with learning disabilities and autistic people, how their lives are not valued, and how their own lack of confidence in their own quality of life can lead to kind of changes in perception of those who are caring for them. We saw it during the pandemic, how people with Down syndrome had a 6 times higher death rate. A lot of that was due to do not resuscitate, assumptions being made about quality of life. My research in the Netherlands has found that the Netherlands is unusual in that they actually provide case histories of people who've had euthanasia. And it is normally euthanasia in the Netherlands, I think 96% of cases, because it's easier, it's more effective, because the complication rate from physician-assisted suicide is so high. And so the learning disability and autism community, we didn't expect to find that they were represented among those euthanized, but they were. We found in our study 38 cases described. This will be an underestimate because they're not all described. We found 38 cases of people with learning disability and or autism who were euthanized simply because of the symptoms of having a learning disability or autism. That's the sort of safeguard that I suppose I'm concerned about. I'll stop there, but
okay. Thank you for that's a very good setting of the scene. And then, Baroness Meachie, you've introduced legislation on this subject, but staying away from that, because we'll come on to the nuts and bolts. But why are you so identified with this subject and wanting a change in law? Why do you care so much?
Right.
What's your lived experience?
Chair, I should declare my interest as Chair of Dignity in Dying at the start. I'm a former social worker and a Quaker, and I suppose I've just spent my life really trying to listen to people's needs, trying to reduce unbearable suffering, and trying to protect vulnerable people. At the moment, some people have to choose between suicide, suffering, or Switzerland. Future generations are going to be appalled that we've taken so long to put this right. If we think of patient autonomy, for many years, polls and surveys have shown that the huge majority of British people want an assisted dying law. 86% of disabled people want this. They want an assisted dying law for people who are terminally ill and who are mentally competent. It's very clear that is where the support lies, both for non-disabled people and disabled people. We know that choice and some control at the end of life will bring tremendous comfort to dying people. Relieving unbearable suffering. Terminal illness brings unbearable suffering in various forms. Obviously, uncontrollable physical pain is one such form. But another is endless nausea and vomiting, maybe because of opioids and an allergy to antiemetics. Another is fecal vomiting, which can recur and recur. Another is a fumigating tumour, creating the most appalling odour that the patient cannot get away from. Other people don't want to come into the ward because of the odour. The patient cannot leave it. Or a complete and utter loss of the ability to move, maybe because of motor neuron disease. These patients towards the end of life are unable to swallow, to speak, to eat, to drink. They're existing, they're not living. We all want more and better palliative care, of course we do. But however good palliative care is, it will not be able to eliminate the unbearable suffering of many of these people. Protecting vulnerable people. At the moment, patients stop eating and drinking. They stop taking their medication. They'll leap off a bridge. They'll try hanging themselves. There are no safeguards or regulations to check that these people are not under coercion from a nearest relative to shorten their life. An assisted dying bill will introduce really strong safeguards involving 2 doctors, of course, and a succession of interviews with the patient to make sure that they really have a sustained wish for help to die, and interviews with relatives to check their motives too. Jeff Whaley, an MND sufferer, who went to Switzerland, wrote to every MP complaining of the hypocrisy and cruelty of the current law and pleaded with MPs to change the law so that others would not have to suffer as he had suffered. But what about healthcare professionals? My daughter's a doctor. I'm very conscious of the historical issues around assisted dying for doctors in particular and nurses. But of course the medical profession has changed tremendously over recent years. The BMA and the Royal College of Physicians, for example, were opposed. They're now neutral, having consulted their members. Why? Because the BMA survey, for example, the largest survey of doctors on this subject ever, found that far more doctors were in support of assisted dying than were against it. 50% supported and 39% were opposed. And internationally, things have changed too. The number of states in the US that now have assisted dying legally have more than doubled in recent years. All the states of Australia, New Zealand have all legalised assisted dying since 2017. Countries are on the move in Europe and also, of course, Scotland, the Isle of Man and Jersey.
Okay. Thank you for setting the scene that way. And then just finally, Baroness Finlay, your experience that drives you to speak publicly on this sensitive subject.
Thank you. I should declare I'm a palliative medicine physician. I've worked in the field since 1987 and I have looked after thousands and thousands of dying patients, as well, of course, having my own experience of people very close to me dying. I've had many, many conversations with people who are dying, people who are in absolute despair. I had a patient back in 1991 who was desperate for euthanasia. 4 of us thought that his prognosis was 3 months. He, with great difficulty, and I was there till 11 at night, persuaded him that I would try and relieve his symptoms, and he said he'd give me 2 weeks before he killed himself. 11 years later, he phoned me because his wife was dying. She died in my care with his children at her bedside and him in a wheelchair. He is still alive today. He's just an example of how wrong you can be. I've had many conversations with patients where they've said, I never believed that I could feel so much better again. The one thing that palliative care and assisted dying have in common is that they are very poorly understood. And that's a real problem. We have the post-shipment effect with opioids, unfortunately, and now clinicians are reluctant to prescribe the type of dose which actually many patients need, so it takes a bit longer to get there. As for nausea and vomiting, I've been involved in the research, and the situation now is that we can control intestinal obstruction well. Smell from fungating tumours doesn't happen like it used to. I saw it happen years ago, but not today. Modern medicine has changed. I had the privilege of working in the Netherlands with a visiting professor, as a visiting professor, and I've been out with the GP to observe these conversations happening. And it was really striking how you end up going down one road and the clinical thinking to think about other ways of controlling symptoms. It becomes very difficult. And this was a very, very good GP. I've been involved in providing education all over the world. Nowhere else has got the level of palliative care education that we have, but it has only been in less than the last year. It's the Health and Care Act, which finally puts palliative care as a core part of the NHS. Until now, we haven't had that. And that becomes really important. I've seen patients who have been suicidal have really discussed whether or not they go to Switzerland, but actually those requests and that suicidal ideation disappears when they get the care they need. And I think the last thing I would say is that my own mother was very strongly in favour of euthanasia, and when she was dying and we thought she had 6 weeks to live, she was extremely angry with me that I'd opposed it. 4 years later, she said that she was really glad and that she had had the most incredibly rewarding time seeing her grandson born and so on. So I think that was just an illustration to me. I've been on the receiving end of the conversations on many occasions.
Okay, thank you very much. I think it was important at the very start of this inquiry to hear those lived experiences, or opening statements. I don't like that term, but people know what we mean. For the rest of the session, obviously, we just need to keep our answers significantly shorter than that, because obviously we won't let members come in, which is what they're here to do. Chris Green.
Mr. Chairman. Lord Faulkner, I'm just wondering how you would judge, or what your understanding of the change in perception the public would have of doctors or the medical profession if we introduced assisted dying or assisted suicide.
I don't think there would be any significant change in relation to it. In those countries where assisted dying has become permitted, for example, in Oregon, a significant majority of doctors are willing to participate in the process. There's no evidence that that's had an impact on people's views in relation to doctors. I think that people look to their doctor when they are dying, and although I completely agree with what both Sheila and Elora said about the fact there's not enough discussion about death. Very many people are aware that they are dying, and they look to their doctor to help them in relation to that.
Your opening comments in terms of the experience of a friend was quite narrow in terms of how you set the scope of people who would be included. Would the practice of a law that you would perhaps favour, would that scope be similarly as narrow, or would it be broader?
Well,
and if it were broader, what scope in a few years' time, 5, 10, 20 years' time, would there be for opening up that scope?
As far as I am concerned, the scope would be only those who are terminally ill. They would require a diagnosis from 2 doctors, and a High Court judge would have to say it was okay to go ahead with an assisted death. The period of time I've suggested is 6 months. There's been debate about that, but broadly, only those who are terminally ill would be within the scope of the assisted dying bill that I proposed. And prior to the bill that I proposed in the Lords, Lord Joffe proposed a bill. He made it absolutely clear that he wanted to go wider, perhaps to unbearable suffering. I'm incredibly opposed to unbearable suffering as the route. I'm only in favour of terminal illness. Lord Joffe's bill was defeated 2-1 in the Lords. My bill effectively got through unopposed on a second reading, and when there were votes, they were all in favour, because the terminal illness scope is the one that I favour. If you start with a terminal illness scope, then history tells us, looking at other countries, that it doesn't expand. You can go for 2 routes. You can go for unbearable suffering on the one hand, which is, this is not the only country where it's been done, but if you look at the Low Countries, it's been done there. Or you can go for terminal illness, part of the way that you help people when they are terminally ill, which is more the Oregon route, and by and large the scope doesn't change.
In the Low Countries, or Belgium, for example, where you can have assisted dying or suicide of children, societies change.
Yeah.
And one of the reasons why we're having this debate now, or we've had a succession of debates in recent years, is because the attitudes of society has changed. Now, once assisted dying becomes more commonplace, more accepted, the scope, surely there's going to be pressure to extend the scope. And if it were to include other groups, because assisted dying across the world is still relatively new, there would be pressure to include wider groups, including children, and surely at that point the perception of the relationship between a patient and doctor would change.
First of all, you're much better able to judge than I am what public opinion is, because I'm an appointed peer. For what it is worth, my view that the idea that in this country a perception would arise that it was okay to allow children to have an assisted death is completely for the birds. That will never happen in my lifetime, I'm sure, which has obviously got a limited span. But I think if you look at it going forward, that seems to me to be incredibly unlikely. My feeling about what the UK will wear is they are in favour of terminal illness assistance, but nothing more. And that's absolutely my view. And that's where the Lords have got to.
Thank you. Baroness Hollins, the same question to you in terms of the perception of the relationship between patients and doctors. Do you think that would change initially, and perhaps would it change over time?
Oh, hugely. That it's such a sensitive relationship. I'll just give one example. In the Netherlands, a friend of mine, his mother was dying, and her mother was being asked every day, would you like to take the drugs now? Because the culture had changed. The culture, the assumption is that this is an option, and that's my worry, that it's an easy way out. On a personal note, I just
Can I
changed
just clarify? Yeah. So someone goes and they're anticipating medical treatment, and they're actually given an option of assisted dying.
Yes, basically, and that just is too difficult. And I think on a personal note, I was visiting a GP with a family member who had a terminal illness, and this doctor made it clear that this was an option that they would strongly support. We changed our doctor. We didn't actually feel comfortable. being with a doctor who, even in that first conversation, was raising that as a possibility. Talking about Switzerland, for example, not something we wanted to hear. We wanted to know that we were going to get all the support and be directed to the right support right at the start. So I just think it does change things. The culture, the attitude, everything changes. It's such an important relationship. When people are in a vulnerable situation and, having a life-limiting diagnosis does make you vulnerable, whoever you are.
Do you share Lord Faulkner's confidence that if it were introduced with very narrow, very clearly defined terms, that would actually be a sustainable position over 5, 10, 20 years?
I cannot see how we can do that safely. It's such a small number of people we're talking about, but actually if you look in any other country where it's been legalised, that has changed. And that's the difficulty for me, that it just, and we look in Canada, people talk about Oregon, Canada and the Netherlands are much more like our legal system and our culture. And it has just immediately opened right up. I'm particularly concerned about the extension to people with mental illness and to people with, to disabled people and particularly to people with learning disability and autism, who are so open to suggestion. Very, very difficult.
Conscious of time, if I can just go to Baroness Meacher and then Baroness Finlay, just to comment on what you've heard so far.
Well, Baroness Hollins has referred to Canada. They are an absolute outlier, Canada, because unusually the Supreme Court in Canada opened up the issue of assisted dying through a judgment which implied a broader law. The legislature were then under pressure to introduce assisted dying, and they did so in 2 stages. One, to limit it to terminally ill people with mental competence, and stage 2 respected the decision and judgment of the Supreme Court. The courts in the UK are absolutely clear, and we've taken a case through the courts, so I'm very, very conscious of it. The courts will not make a judgment on this issue. The courts in the UK are absolutely clear this is a matter for Parliament. Parliament will pass a law on assisted dying when Parliament is ready to do so. That is absolutely crucial. And the majority of jurisdictions that have passed laws on assisted dying have done so restricted to terminally ill people who are mentally competent. And not a single one of those jurisdictions has broadened the scope from the initial scope. That is incredibly important because that is what I believe will be the case in the UK. We're a highly disciplined country. That is the route I believe we will follow. We will have the narrow law for terminally ill people who are mentally competent, and it will remain thus.
Thank you. Baroness Finlay.
Thank you. I think it's important to remember that defining terminal illness is extremely difficult. In the bill that Baroness Meacher proposed, an 18-year-old with anorexia would have been eligible. A diabetic who was insulin dependent would have been eligible by refusing their treatment. So,
in that sense, by refusing your treatment, you then have a terminal condition. Is that?
Well, absolutely, and we know that sadly, anorexia is a potentially fatal condition even now, even though our NHS investment has improved survival by 22% in recent years, but it's still a potentially fatal illness. I think you also have to remember that diagnostic error is quite common. There have been cases in Canada of people who had euthanasia but actually never had the illness that they were thought to have. 1 in 20 post-mortems show that there's been a diagnostic error in this country. That was evidence from the College of Pathologists. We know that the prognosis is just about impossible. In fact, Ray Tallis, in evidence to the previous Select Committee in the Lords, described it as a probabilistic art. And the College of GPs said at 6 months is pretty desperately hopeless being able to predict prognosis. In terms of the law itself, I think it would only be a very short time until a challenge was brought in the courts claiming inequality for whatever reason, if you try to put firm boundaries around it. The Canadian experience, I don't think we can ignore. It has split the medical profession. In terms of Oregon, I've understood that only 2% of doctors there actually prescribe and are involved in this. So to say that it's widespread, it is not correct.
Just so I understand that, because the point made before is that in Oregon there's popular support from doctors, but actually you're saying in terms of those actually participating, it's a far smaller group. So is the question over, you might support it, but you wouldn't participate in it?
Yeah, and the BMA survey that was referred to also showed that the highest opposition was amongst those clinicians who deal with these patients, look after these patients all the time, particularly my own specialty of palliative medicine, but also geriatric medicine, clinical oncology, renal medicine. That's where the opposition came. When you ask people, would you be willing to participate in the processes, the numbers go right down. So theoretically, they think, well, that might be okay, but when they think it through, the numbers drop. The BMA also did a study called the End of Life, ELPAD, End of Life Care and Palliative and Assisted Dying study in depth, which is well worth reading, and it showed that the public group that were in there, as well as the doctors, the more they learnt about it, the more they became cautious about it. I do think we have to remember about the drugs that are actually used. Nowhere in the world have these drugs been approved by any authority for repurposing. People are completely unaware. Last week, 100 clinicians were asked, do you know what drugs are used? This was in Southampton. None of them knew the doses. It is 100 tablets of barbiturate or 150 tablets of a mixture of Valium, amitriptyline, digoxin, and that's an awful lot of tablets to swallow. The other thing with euthanasia, over 2/3 of patients last year in Belgium were given a short-acting anaesthetic agent, but then they also were given curare. That meant every muscle was paralysed. They will have looked as if they're peaceful, but they were dying of asphyxia. People are just unaware of that. And if I can just add one thing, I did ask many years ago now for somebody to do a study to see whether patients given these cocktails in euthanasia regained consciousness before they died, because there was a study from lethal injections in executions that showed 80% of people probably regained a degree of consciousness, but nobody's undertaken that study. So we're dealing with something which is really unknown. The end point, yes, it's death, but actually I think we can manage death better and differently. We don't have to go down the route. And I do think you do have to look at Canada, because the experience in Canada is worrying.
Could I just correct two things that Baroness Findlay said? First of all, in relation to Oregon, the position is that the median time to unconsciousness after ingesting the medication is 5 minutes, and the median time to death is 30 minutes. Nobody is reported to have regained consciousness with the medication. And the second and separate...
I'm sorry, 9 people have.
And the second point is that she suggested, and I was surprised by this, that the courts could set aside a bill that Parliament passed for assisted dying, which is completely untrue. The reason why Canada is different is because they have a Charter of Rights, which allows the Supreme Court to set aside or require legislation. So I defer to Elora on all medical matters, but on legal matters, that was quite a leap.
Pulled rank like that. Look, we are going to move on. Colleagues know that we won't be asking all 4 of you on each question, because we've got a second panel and we're never going to get there in daylight hours at this rate. Lucy, Alan.
Thank you, Chair. I wanted to ask about the ethical considerations for the medical profession, because clearly all medical professionals want to alleviate suffering of patients, and also there is now a trend for the profession to move towards choice and autonomy about care and treatment, putting the patients at the centre of that. So perhaps if I could start with Baroness Hollins. Do you think that there is a concern for the ethical considerations around medical professionals when they are being faced with suffering of their patients, and a lack of clarity in the law?
Well, I think the law is clear at the moment. I think the ethical issue for the doctor is to meet the needs of the patient, and if you don't have the adequate competencies yourself, to refer to somebody who does. And we have the opportunity in this country to refer to palliative care, to palliative medicine, and we have so I mean I think there is. Baroness Finlay is probably more au fait with the ethics, because I think you're still on the ethics committee at the BMA, so you might prefer to address this with her.
Just to give it a bit more sort of context. Say, for example, a doctor was faced with a terminally ill patient who was suffering gravely, and that doctor decided to give that patient a little bit too much morphine. Is that not something that creates ethical considerations?
I think that's a misunderstanding. People misunderstand morphine. Morphine, the way that morphine is used is to titrate it. Again, it's not my specialism, but I was a GP for a number of years, and I've been a psychiatrist, and I've been involved in a lot of debates and discussions around this. But and I've also seen and been with family members who've needed morphine at the end of their life. And there's often a reluctance to take it because there's an assumption that if you take too much morphine, it will kill you. It's not really like that. If you keep on top of the pain, the morphine will actually allow you in the end to die. It's not that it kills you, but it allows you to die. My understanding is that it's pain that keeps you in suffering. But if you take morphine, then the natural process of dying can take place. It's about skill and titrating the dose. Again, this is Baroness Finlay's expertise.
Can I just say,
yes, please do.
I think that there is a real misunderstanding. If you're in the street and you don't have pain and you take an overdose of morphine, then yes, you may stop breathing and that would kill you. In our patients, you titrate the dose of morphine against the pain to be below the level of toxicity. I've seen patients who've had an accidental overdose, sometimes huge, because someone got the dose wrong for whatever reason. They just have a good sleep and wake up again afterwards. It's really difficult to kill people with morphine. That's why the mixtures used in those countries are not based, they're not overdoses of morphine.
If a patient says to a doctor,
yes,
can you give me more morphine? And the doctor thinks this will probably finish the patient off. Is that not an ethical dilemma for that doctor, that they would be outside the law but acting in accordance with the request of their suffering patient?
I think, sadly, that I'd say that probably reflects a degree of ignorance of the way that opioids work, but also how to handle it. If somebody says, I'm suffering unbearably, you must go back, find out why, diagnose what the underlying cause is, and think again. Morphine isn't the only way of relieving pain. There are lots of other ways as well. You may have to involve other people, get other people in, but actually people are terrified of pain. Of course they are. Nobody wants to be in pain. But it isn't the main reason either that people go for assisted suicide. So if you look at the Oregon data, the main reasons are about being a burden. Pain or fear of pain comes way down the list. And I would stress fear of pain, because actually we don't know how many of the people actually had unrelieved pain. Pain isn't the problem, though.
What about patients being able to make their own choices and patient autonomy? So if you're dying, you know you have limited lifespan left, you are in pain, your family is seeing you suffer. Yeah. Patient autonomy is something that the medical profession is moving towards in terms of choice and placing the patient at the heart of what is done. What sort of ethical considerations are raised by that?
The thing about choice is that you must have information. Choice is meaningless unless it's an informed choice, and you need to know what the options are and have them available. I pointed out that we've only just incorporated palliative care as part of a requirement for NHS provision. We still have parts of the UK where it's not available, and it needs to be. But we are getting there. In terms of the patient's choice as well, you have to ask why, what's behind that request to end their life, what is going on. If you look at suicide rates overall suicide rates, the ONS did some work and it was misinterpreted because what it showed is that people given a serious life-limiting diagnosis are at highest risk of suicide at the time that they get the bad news, and their suicidal risk drops down with time afterwards. If you look at suicide rates in countries that have gone down this road, they're all higher than us. Our suicide rate in the UK is 8.4 for 100,000. In Oregon, it's 18.3. That's not assisted suicides. Those are mostly gunshot suicides. So you don't even solve that problem.
Very limited time,
Yeah,
and I was
sure.
talking about ethical considerations
Yeah, sure.
for the profession. I wonder, Baroness Meacher, if I could just ask you about the ethical considerations for the profession, given that the law is, and we heard Lord Faulkner say this, that the law is unclear. I mean, I'm not clear as a layperson whether it's the doctor's responsibility, the Director of Public Prosecution's responsibility, the court's responsibility. Lord Faulkner is clear it's Parliament's responsibility. If you're a medic and you are going to expose yourself to a law that's not entirely clear, does that create ethical considerations?
I suppose I take it the law is clear. It is not acceptable to assist somebody to die under the current law. A doctor will know that. So the ethical consideration for a doctor, in my view, is that here they have a patient suffering unbearably, pleading with them for help to end their suffering, and they can't end that suffering legally. Therefore, I'm assuming they won't do it. So that, for me, is the ethical dilemma under the current law, which, of course, an assisted dying law would eliminate. Then the autonomy of the patient would really come to the fore. If the patient really wants to die, is pleading for help to die, then a doctor can help that patient. The important point here, though, is that Laura Finlay referred to the 6 months rule. In jurisdictions that have legalised assisted dying, people request the medication and ultimately take it, normally within a week to 10 days of the predicted death. They don't take it 6 months ahead of time, and therefore people are much, much clearer, very close to death, that this is indeed the future for this person. They will die within a week to 10 days. What it means is that in the lead up to that period, the patient knows when they really get to the end that they're suffering whatever it is, vomiting, fumigating wounds, and they do happen, these things, that unbearable pain will be able to be ended by a doctor. And it is that security and reassurance that is so important to people and means that dying people have a much better end-of-life experience. Added to that, of course, you've got the fact that doctors in these jurisdictions where they have assisted dying are much more able to talk openly with patients, and there's a lot of evidence about this, about the patients' problems and issues.
Bring in Lord Faulkner while I may. Keir Starmer, as Director of Public Prosecutions, made the point in a speech in 2015 that relatives will be acting very usually for compassionate reasons, and it is extremely rare that he would have seen in his capacity as DPP any prosecutions against relatives. He did say that medical professionals are in a slightly different position, and I wonder if you just comment on that point. And
you so want to talk to somebody when you are terminally ill, and you might want to consider whether or not you want to take your own life by going to Switzerland. And Elora and the entirely admirable palliative care profession will try to persuade you not. If you talk to a doctor at the moment in the United Kingdom, England and Wales, not Scotland, and he or she says, well, look, I've heard what you say, you want to go to Switzerland. If they encourage you in any way, they may end up being prosecuted under the law. They will not have the protection of the DPP's statement, which only applies to relatives. So the only assistance you can get under the mess that is the law at the moment is amateur assistance, well-motivated assistance, but amateur. And my experience, having looked at this a lot since my own personal experience, is that people feel alone. They do not want to talk to their own family about taking their own lives. They can't talk to the doctor, so what they do is they take their own life without telling anybody, and it is absolutely hellish for those who are left behind.
Thank you.
Fascinating stuff. Well done. Thank you, Lucy. Right, we're going to go to Rachel Maskell and then Paul Blomfield, starting with you, Rachel.
Thank you very much. Looking at the area of commonality here, we're looking at everybody wants a good death, and within that, without fear as well. Baroness Meacham and Lord Faulkner, if I can turn to you first. We've heard today that difficult deaths can be addressed by palliative care. For instance, pain. We've heard about certain tumours, vomiting, and so on can be controlled. So is it that the advances in medicine, which are forever progressing, can actually address that fundamental issue about having a good death?
All the evidence that I have seen, and I've seen a lot of it, suggests that we all want better funded palliative care, but that will never be able to eliminate unbearable suffering for everyone. Yes, for the majority of people, that is so, but there will always be a minority of people who will suffer unbearably in the ways that I have indicated. Obviously, uncontrollable physical pain is just one of those forms of unbearable suffering. I suppose the one that I see as the most frightening is the complete loss of ability to move, particularly caused by motor neurone disease. And I met Jeff Whaley, who went to Switzerland and who I referred to in my opening comments. The fact is, not to be able to swallow, to speak, to eat, to drink, to scratch an itch, to deal with a pain, not to be able to move in any way or communicate because you can't speak any longer and you can't move to signal. This is a form of unbearable suffering that I believe, where I believe if the person really cannot cope, they should be assisted to end their suffering. And that was the view of Jeff Whaley that he put so strongly to every MP in this country.
Can I just ease you out a little bit more on that issue? So somebody, for instance, who has a learning difficulty could be in that situation, or a profound disability which they've had all of their lives could be in that situation at all. What would you say to the person with learning difficulties?
Well, I've worked with people with learning difficulties, severe learning difficulties, and it's remarkable the way dear people can find a way of communicating if they're not paralysed. But the fact is, complete inability to move is something completely, else, if you know what I mean, something completely different.
Do you want to comment too?
I've got nothing to add to what Baroness Meacham said.
I just want to also pick up with you about what we've heard very powerfully today, the lack of a comprehensive advanced palliative care system across the country. Were that to be available, do you believe that would remove some of the fear people would have about not being able to access high quality care at the end of their life? To either of you.
I think the better the palliative care, the better the situation would be for some people. But I think there is a group of people who, no matter how good the palliative care will be, will always find the position they find themselves as being intolerable. Hospice UK said the following: it's not in doubt that some people will have what they or their families consider to be a bad death, despite the very best care being made available across all settings. Everyone has their own level beyond which they may feel their quality of life has become unacceptable. And why you feel your quality of life has become unacceptable may in some cases be the physical restriction or pain, or it may be the lack of dignity or the lack of control that makes it impossible. But I think most people who have done work in this area think there will always be a group of people who find the idea of what is coming, which may not be pain, it may be a lack of dignity or a lack of control, just make the prospect unbearable going forward.
Thank you. And just one more question to you. either Baroness Meacher or Lord Faulkner, 6 months of from a diagnosis to or of a prognosis of death. Is that with or without treatment? Because one of our kind of discoveries in Oregon was that somebody could have a prognosis of 6 months without treatment. However, with medical intervention, they could have a quality of life. We met somebody who had lived 23 years.
I mean, 6 months is in the context of what's happening then. If I'm not taking treatment and I've only got 6 months to live, then that's 6 months. If, for example, I've got treatment, there's lots and lots of illnesses which, if you're treated for them, you can last forever and ever. And if you're taking the treatment and happy with that, then you've got an indefinite amount of time to live. It's upon it. You have to look at the circumstances of the individual patient.
Absolutely. And as I said before, people are not then going to get hold of and take the medicine until right towards the end of their lives, by which time things are very, very clear. Doctors and everybody around the patient will be very clear about what is going to happen.
Can I take an example? Take the anorexic example, somebody who is not eating, and as it goes on, their life expectancy gets less and less because they become weaker and weaker. Those circumstances, under the bill that Molly and myself, the separate bills we introduced, I would have thought it was inconceivable that a High Court judge would say it's okay in those circumstances. That's why you have a High Court judge. But you need a timing. Sorry, Laura feels tempted to say what the High Court judge would do.
No, I'm not at all.
Okay.
I was thinking that they would fall within the definition.
They would,
and therefore it wouldn't ever go to court. A young woman with severe anorexia nervosa may well have a very poor prognosis. But if she does come out the other side, it's usually women, sometimes men, then they can go on to have a completely full life.
Yep, I agree.
I wanted to come on to the issue actually of withdrawal of food and fluid, because clearly that doesn't lend itself to a good death for people. Could you just talk through your experience about the implications of that? Because that is currently legal for the withdrawal, a patient to choose for the withdrawal of food and fluid.
Right. Within the clinical context, it's really extremely rare for patients to decide that they don't want food and fluid because that is basic care. They must still have all care, even if they've refused all treatment. If I can go back to motor neurone disease, where patients may decide they no longer want to continue with, for instance, supported ventilation, they withdraw their consent and they are supported and looked after as they die. They're dying of their motor neurone disease that they would have died of months or weeks previously. In terms of fluids, I actually think that probably the medical profession have been overcautious about putting up, for example, subcutaneous fluids on patients at home just to keep them comfortable. It's really easy to do. And patients can have fluids even if they don't want to eat. It is up to the patient, and you must discuss all these things with the patient quite openly and listen to what their concerns are. And also ask them if there are other things that they would want to do in their time and are not able to do. That conversation about where are you going? I had a patient who wanted to go to Dignitas. He was absolutely adamant, it's just he had pain and needed pain control for the journey. In that conversation, when I asked him, is there anything else you've always wanted to do, and prompted him, he then told me that he'd actually always wanted to go on a cruise. Well, I'm no travel agent, but we arranged for him to go on a cruise with his wife. When he came back weeks later, he said he'd had a wonderful time. I thought he now would want to go to Dignitas. His comment was, no, I actually want to go on another cruise. So he went on 3 cruises, and then in the middle of winter he went to Porthcawl Beach, and then he died subsequently. It was very, very cold out on Porthcawl Beach. But actually you need to know what patients really want and what's motivating them, and you need to understand their fears. And listening is the core skill of everybody in terms of understanding what needs to happen. And going back to the ethical dilemma, it is about listening to what people want and weighing in the balance the harms against the benefits with the patient and listening to what they want and detecting pressures on them, because we mustn't forget about coercive pressures and we mustn't forget about abuse. The data is that about 1 in 5 people over 65 in the UK have been affected by abuse. That data from all over the world is borne out, sadly. Elder abuse is really rife. It is not picked up by the clinicians. It's only picked up by the clinicians when it's physical abuse, but most is financial, emotional neglect and so on. And those are pressures on people. And I've had patients who, when they have revealed that they were being abused, their requirements for analgesia dropped dramatically, because actually we were able to support them and sort out the problems that they had.
Thank you. May I ask just one more question? That's around these difficult deaths as I've categorised them. And how advanced is medicine for dealing with every scenario of a difficult death? And how could that be dealt with under palliative care to ensure that somebody didn't have such a death?
Okay. Thank you for asking that, because I think it's really important to be clear that nothing in medicine is 100%. If you have meningitis, you'll be given antibiotics, but it isn't 100% that they will work. Nothing is 100%. However, access to high-quality specialist palliative care is still inadequate around the country. We're getting there. We're more advanced than any of these other countries. It's worth remembering that Els Borst, who took the law through in the Netherlands, went on to say, and I can actually quote her, she said, "In the Netherlands, we first listened to the political and societal demand in favour of euthanasia. Obviously, this was not in the proper order. And it's only just recently that the Netherlands are developing specialist palliative care as a discipline. The training that people have in this country is much greater than in any of these other countries. And I think you have to look at the balance. How safe is safe enough? And the evidence from the other countries is that there will be some people who die when actually their death was based on the wrong information. The information they had in making that choice was misinformation, and that's the problem. And I think you also have to look at what is the acceptable number of unacceptable deaths through error and decide that if you're making a law that allows doctors or anybody else to give lethal drugs to a patient at their request. Because it is a balance of harms, and we have a duty to the most vulnerable in society, not only to the most vocal in society.
Thank you. Rachel, are you concluded? Excellent. You're pondering there. Okay, Paul Blomfield.
Thanks, Chair. Baroness Hollings, you talked, and I'm sure we'd all agree, that we need to have more mature conversations about death. Would you accept that as part of those conversations we would have to recognise that even the best palliative care can't provide a good death for everybody, as Hospice UK have suggested, Lord Faulkner said?
I think the difficulty, there's a real difficulty, because I think there's an awful lot of this is to do with fear, and fear throughout the system, on both sides, patient and clinicians, I'm sorry, but my mind is full of the previous conversation about motor neuron disease and dignity, and I feel that I should just say that I have a family member with motor neuron disease at the moment, and but what's really interesting about it is that in my family we're not really afraid of what you describe as a loss of dignity, and that's because 17 years ago my daughter was stabbed and paralysed and has a high-level spinal injury. She didn't speak for many, many months. Her life could not be more dignified. Okay? She is still paralysed, but she lives a full life. She's not afraid. And in our family, we're not afraid of disability because we've actually met it and lived with it. And I've worked my life. So motor neurone disease doesn't have the fear, attract the fear that it does in some other people who are less familiar. There's no loss of dignity in any of the things which have been described. I think it's fear which is behind it, and fear causes pain. And I think that's it's not just a physical issue, it's partly a psychological issue. And being able to sit and listen to people and hear what their fears are changes things. I sat with my daughter's mother-in-law when she was dying 18 months ago. She was afraid. She was afraid of all sorts of things. She was afraid of taking pain relief. But when she'd had the pain relief, she was able to just settle and reflect on her life and spend time with her family. The pain relief worked, and yet she had one of those diagnoses that everybody said is the most terrible death. She didn't have a terrible death. She had a beautiful death at home. And I think it's those psychological issues which are actually really, really fundamental to our understanding about death and talking about it. The number of times that somebody will ring me up and say, my mother's dying, she's in pain, she's in hospital, it's terrible. And I said, has anybody talked to her about palliative care and the fact that she's dying? Is everybody tiptoeing around the subject? And it's always, well, nobody likes to mention it. Nobody likes to mention it. As soon as it's mentioned, as soon as the palliative care physician or clinician is invited to come in, things change. And it's the lack of addressing the issue. Doctors are not comfortable with saying to their patient, you are dying, how can we help you? That's the difficulty.
I'm really very sorry to hear about your daughter. But that wasn't my question.
Yes.
My question was, Hospice UK, as Lord Faulkner has indicated, have said, in their view, that even the very best care can't avert a bad death for some people. Do you accept that?
I think that is going to be true, but I don't think it's as widespread as people think. And I think the point about it is simply, and that's why I was talking about the psychological, because I think the psychological is actually underneath an awful lot of this.
Thanks very much for that, and accepting that is, in fact, the case. I wonder if I could just explore with you the consequences of the current law, because we often in this debate focus on change, but actually the current law has implications for people. Baroness Finlay, you talked about the ONS study which showed that people with terminal illness are twice as likely to take their own lives. Let me finish my question. And it's estimated that's around 650 people a year. They are lonely and often very difficult deaths. My father was one of them. And he didn't, as you suggested, make that decision at the point of diagnosis. He actually took that decision shortly after he'd sat down with Macmillan's nurse and had been through what his last months might look like. So I guess my question is, are you satisfied that the current legal settlement has no negative consequences for individuals who take those decisions and indeed for their families?
Can I say, first of all, a suicide is a devastating event for anybody, as is even an attempted suicide, because it raises all kinds of questions in those left behind, which are particularly difficult. And thank you for speaking openly, because I think it's important that we know where people come from. In terms of, I'm back to the question of balance. Sadly, and I say sadly, there will always be some people for whom carrying on is not tolerable. But the rate of other suicides as well in the country is not lowered. The rate of suicide amongst people who are dying is not lowered by having this change in the law, which is why the suicide data from countries that have changed the law becomes important. And I think, sadly, within our lives, we will not meet the needs of every single person in the population. But I'd go back to that question that you have to ask is, how safe is safe enough if you change the law? You talked about 650 suicides a year. If you look at the data, even if we took the Oregon figures, which are meant to be the lowest, Emily Jackson, who has been known to be a supporter of a change in the law, gave a lecture a couple of weeks ago, and her estimate is that there'd be 5,800 assisted suicides in the UK with the Oregon figures. If we look at the figures from Canada or the Netherlands, there'd be probably tenfold that. And then you have to look at, what do you want your clinical staff to do? Do you want your clinical staff to be looking after patients who are dying and working to relieve their distress, or are you going to take them away from that in order to process assisted suicide requests? And the data from Australia suggests that it takes 60 hours of clinical time. Now, we know that we have an enormous shortfall of clinicians in this country already, and you're going to take thousands of full-time equivalent hours out of the clinical services if you put this as a clinical duty by changing the law. So I'm back to that question of balance. You take people away from clinical care to assist suicide, you decrease the number of people who are there to look after people who are distressed and work to relieve their distress. And I don't think anyone should underestimate the shortfall in clinicians that we have in this country.
And with the greatest respect, that wasn't my question. My question was, do you think there are any difficult consequences from the existing law?
I would say there are difficult consequences from every law that we have for some people. So to say no would be very naive, actually. There will be some people who want to go to Switzerland to kill themselves, but we have people who go abroad for all kinds of activities. We don't police those activities of them going abroad. We have laws in our country about how we behave towards our citizens. And on balance, and back to that, I do think that on balance our law is safer than the evidence from countries that have changed the law.
In that context, you've acknowledged obviously that people go to Switzerland and other people take their own decisions to take difficult deaths. Do you think the current law provides any... The debate around a change in the law is about safeguards.
Yes.
And about the worries about coercion is a factor. What are the safeguards in the current law? How do we know that people going to Switzerland haven't been coerced?
Well, the Director, that's why the Director of Public Prosecution's guidance is that, and why our law was changed, that you don't prosecute people who take their own life, because that would have been completely inhumane. But the dangers are of coercion, the dangers are of pressure. And of the Director of Public Prosecution's cases, I think some have, I can't recall the exact number, but I can try and get them for you if you want, that of who have proceeded to prosecution because there was certainly malintent behind the persuasion. But when you look in countries where the law has changed, that doesn't seem to go away either. You don't remove the ability for families to coerce somebody. The Canadian experiences of patients being offered to have lethal drugs. We know of the athlete who was offered euthanasia rather than a ramp for her wheelchair.
You would agree that there are no safeguards in our existing law, and the risk of coercion is a factor that needs to be taken account of, either under a new legal settlement on assisted dying, or indeed under our current situation?
No, I think the safeguards in our current system are greater than the proposals that we've seen on the table. The bill that Baroness Meacher put forward, we put down amendments to. Yeah. We said quite openly that we were wanting to tighten the so-called safeguards because we didn't think that they were verifiable. Actually, nobody from the campaign side has come to discuss any of those amendments with us. There's been an accusation that they were vexatious. They were not. They were to try to make it safer in the event of that legislation passing. And I think you have to be aware that if you're going to have safeguards, they must be things that are verifiable. And the proposals that we've seen have not had verifiable safeguards in them.
But there are no safeguards in the existing system.
Well, if you look at the way that the law has changed in other countries, because that's the basis. I know it wasn't your question, but I do think you have to look at the evidence. Nowhere is there any monitoring of the consultation itself in which the discussion happens over assisted suicide or euthanasia. That was not a proposal in any of the legislation either, that those consultations will be monitored. The suggestion of a second doctor had nothing about the relationship between the two, nor the amount they're involved. So if you're going to have safeguards, they must be ones that you can verify, that you can go back and audit afterwards.
I'll leave it there, but obviously my question was about safeguards under the existing system, and the sort of safeguards that you describe simply don't exist in our current legal settlement. But thank you.
Thank you, Paul. James Morris.
Thank you, Chair. I'm assuming that even if we were to change the law on the basis of what Lord Falkland said, that we'd still have the need for a mental capacity assessment for the individual. So I wanted to ask Baroness Hollins whether you thought that that would put pressure on our current definition of what mental capacity is, or what the implications would be, if any.
It's such a complicated area. I sat on the Post-Legislative Scrutiny Committee for the Mental Capacity Act, and there are just huge difficulties with it as it stands at the moment, in that very few clinicians really seem to understand how to assess capacity. It's still not fully understood and implemented, and I think it will confuse, or would confuse the situation further. At the moment, it doesn't extend to decisions about an assisted death.
Do you think that the law around mental capacity would need to be updated to reflect any changes that came along with the new law?
I think it. Well, I think it would, but I think it's also just so. It's been found to be such a complicated area. I mean, there's a big discussion about whether we should have a combined mental capacity and mental health act to try to sort of address some of these issues. It would be a very lengthy process to try to get to something which is kind of in any way satisfactory. But I think just the difficulties even of assessing capacity for some quite simple decisions are not well managed within our system. It's a very interesting question and a very interesting area to explore, but it's not something that has a simple answer, I'm afraid.
Frog, do you consider there to be impacts on mental capacity law as a result of the changes that you may propose?
The bills that have been proposed say that the person who decides to have an assisted death has to have the capacity to make that decision. And that's all the bill says. The Mental Capacity Act says, in my view correctly, in determining whether somebody's got mental capacity, you've got to have regard to what the sort of decision is. It's hard to imagine a more serious decision than whether or not you should take your own life. That is a factual decision that both doctors in some circumstances and the courts in other circumstances are used to addressing. It's a very serious decision, but it's one that they are capable of taking. Speaking for myself, I don't think there would be any need for a change in the law, because the question is, looking at this particular person, is he or she in a state where he or she can make the decision as to whether to take their own life? Are they, for example, affected by depression? Are they affected by mental impairment that prevents it? But it's a factual question that it is it is perfectly possible for doctors and courts to make. And although I note what Sheila says, honestly, over quite a considerable period of time, particularly judges have been capable of doing that.
Just hypothetical, perhaps. In the situation that you described about a girl suffering from severe anorexia, do you think, hypothetically, she would be deemed to have capacity to make a decision to end her own life?
I think the danger is it depends on the ability of the clinicians making the assessment. I had the privilege of chairing the Mental Capacity Forum for 6 years, and I have to say it was really worrying to see the inability of clinicians to really assess capacity, particularly fluctuating capacity. Another group of patients where there is a real worry is where there's frontal lobe involvement in the brain, where they can appear as if they're as if they have capacity, but actually they cannot understand the implications of their decision for themselves and others. And only last week I came across a clinical case of somebody who in ICU who appeared to have complete capacity to stop treatment. By chance his girlfriend arrived, and I won't go into the details of it because it's a long story, but he then decided to marry her. And afterwards, he had absolutely no recall whatsoever of any of the conversations that had taken place where he said he didn't want to be treated. But at the time, his clinicians, not just one, but 3 of them, thought that he was absolutely crystal clear that he wanted to stop treatment and would have stopped his ventilation if it wasn't a chance arrival of his girlfriend.
Which indicates that the bills are the most safeguarded route. Because what Elora's talking about there quite rightly is where people decide, maybe on bad grounds, to withdraw treatment, where there'll be no safeguards whatsoever.
Well, the point is that when you're assessing capacity, you have to go back and look again and think again. The clinicians had a tiny element of doubt, which is why they didn't just act there and then, but decided to wait to see what happened with him, even though he appeared to have capacity. And that is a big problem. And it's a big problem in care homes as well, where you've got people who've got frontal lobe involvement.
Thank you.
Thanks, James. I'm conscious we are running behind time, but this is such important stuff, and we will still attempt to finish on time. Paulette Hamilton, finally, in this section.
Right, good morning, ladies and gentlemen. My question is geared at Baroness Finlay. Baroness, you could have had the question, but unfortunately I picked Baroness Finlay. And if you don't mind, Baroness Meacher, it's a really simple question. I'm about families, and I read a report that was published by Macmillan in 2017. It was called No Regrets. The report talked about death. It also talked about that people treated death with a little bit of a taboo, so we don't talk about it enough. It also stated that 64% of people just don't talk about death at all till it's upon them. So my question to you both are, patients and their family, if they're given enough opportunity and support, are they given enough opportunity and support to discuss death and dying before it gets to the stage where people feel isolated, they feel they feel they have no support, and then they take decisions like committing suicide? So that's my question.
If I can put simply, no, they don't have enough opportunity. Even clinicians are slow to refer patients to palliative care early because they're frightened of having that conversation to say that the prognosis is not good, even though we've moved a lot from where we were previously. The biggest group are children. You've already heard that every class has, on average, one child who's lost a parent or sibling and 2 other children who've been bereaved of somebody close to them. And yet in schools, very few teachers, I think it's way below half, have got any training in managing bereaved children. We don't talk about death and dying. During COVID, it really came to the fore as people suddenly became aware of the threat of death from COVID and what was happening. And the other problem is even when people are bereaved, people don't talk openly and just let them talk about the person who's died. So I'm afraid no, and yet death is going to hit everybody. Nobody can escape the fact that we will all die one day. And we as a society need to decide, how do we provide that support and help people prepare?
Thank you. It appears that the doctors are the problem. Marie Curie showed that about 65% of dying people were able to talk to their friends and family about dying, about their concerns and so forth. But a YouGov study revealed that only 16% of dying people had had a discussion with their doctor about what was going to happen as their condition worsened. And this is a very, very serious issue for people, that they just feel they cannot talk to their doctor about their death and dying. And we know from the jurisdictions that have assisted dying that doctors are then much more comfortable about talking with their patients about dying, about pain control, about hospice care, and so on. It opens up the relationship and the conversations between patients and their doctors if the doctor knows that if things become unbearable for the patient, they can actually help them right the way through. At the moment, at the point of greatest need for the patient cannot cope anymore. The top doctor is unable to help, and that interferes with a doctor's feeling that they can actually have those conversations.
So my last point, and I'll open it up, I actually would be really interested to see what Lord Faulkner said. If you were going to give advice going forward, what would that advice be around educating people, talking about things a lot earlier, about this taboo that you've talked about, so we don't get to the stage where all people want to do is end it all? And Lord Faulkner, I'd like to hear what you've got to say on that.
I mean, all three of the previous speakers have indicated there's not enough discussion about one's death, because as Laura says, we're all going to die. You need to be much more open about what are the prospects of how one dies. That will have the effect, I suspect, of reducing much of the fear that is associated with death, and the longer one has the opportunity to talk about death to clinicians that might help them, the better one will be equipped to do it. Even if you have these conversations, for very many people, the prospect of the disability, the pain, the lack of control and the lack of dignity that comes because not everybody is able to cope, as Sheila's family have, with the lack of dignity that comes from death or the lack of control, because different people have different levels of resilience. And for some people, even with the best help in the world, the idea of going through a period where they're completely disabled, the idea of going through a period where they're dependent upon those who love them, is just unbearable. And so you need to have that discussion, what can you cope with? Because people's levels are so different.
Yeah. So I was going to stop there, but what you've said really interests me, because where my parents come from the day you're born, you're hearing about death. You'll be living in a house with a grandmother that's probably on a journey, or someone in the family. So what would your point be about, perhaps in England, we've got this stiff upper lip in the UK, in this part of the world, and we don't talk about it. It's like a need-to-know basis. Perhaps doing things like talking about death at an earlier stage, do you think that would be more helpful and would help people to get to the point when they come to the last stages of their life? You don't get that fear that you so highlighted earlier on. And I'll ask Baroness Ollens what do you think about the point I've just made, and then I'm done.
Absolutely. It's just such a taboo, and we have to learn how to talk through the taboo, and that includes death, but it also includes what you're calling dignity. But I think the dignity comes in part from the comfort of sharing fear, of understanding, of seeing, of participating, of engaging, of experiencing grief. of understanding that this is part of the life cycle. I just, you know, I just think, let's open the subject up. Let's just talk about it. Let's talk about it.
That's a good way to end it. Thank you, Chair.
Very good. Very good, Paulette. Okay, Baroness Finlay, Baroness Hollins, Baroness Meacher and Lord Faulkner, thank you so much for your time and your honesty and opening our inquiry session so frankly. We're going to take a very, very short break where we change our panel and bring somebody in online. Thank you very much. Order, order.
Thank you.
Thank you.
Thank you
for
very much.
inviting us.
The proceeding is currently suspended. 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 The proceeding is currently...
Suicide. We have obviously just heard from 4 peers of the realm, and now we have a second panel. So we have, appearing remotely, Dr. Naomi Richards, who's a senior lecturer in social science and director of the Glasgow End of Life Studies Group at the University of Glasgow. Naomi specialises in death and dying, ageing and old age. We have in the room Dr. Alexandra Mullock, who's a senior lecturer in healthcare law and co-director of the Centre for Social Ethics and Policy at the University of Manchester. I think in 2021, Alex was one of the legal experts to the Government of Jersey's Citizens' Jury on Assisted Dying. That's very interesting to us. And Professor Nancy Preston, who is the Professor of Supportive and Palliative Care at the University of Lancaster. Professor Preston has a strong interest in how people make decisions about their future care She's conducted research about ADAS in the US, Switzerland and the Netherlands, as well as exploring the experiences of British families following an assisted death overseas. So a really interesting panel. Sorry we're a bit late starting, but thank you very much for your patience and for your time. We're going to start with Chris Green.
Yes, Chairman. Dr. Mullock, I'm just wondering, with the deliberations over the Jersey citizens' jury, there must have been a bit of a discussion about the scope in terms of assisted dying, assisted suicide, the scope of people who might be included on that. Could you just briefly highlight how that conversation went?
So the jury were given quite a sort of broad, flexible remit in terms of firstly deciding whether in principle assisted dying ought to be legalised in Jersey, and then subsequently to decide the sort of parameters of that. And the majority of the jury decided that both physician-assisted suicide and euthanasia should be legal, and this should be available for terminally ill people and people suffering unbearably.
Okay, so that's slightly broader than other areas, but in terms of that terminal illness, for example, would there be a kind of 6-month, your prognosis has to be a 6-month prognosis, so there were that kind of constraint as well.
Yes.
What was the discussion in terms of, for example, in Belgium, as I pointed out earlier, children can also be included in the remit. Was there any discussion over that?
No, no, there wasn't. I mean, the jury heard many hours of evidence from a range of experts, including from Europe, and so they were made aware of the approach in Belgium. But they voted to limit eligibility to adults.
Mm-hmm. And in terms of the criteria for adults, were there groups participating in the citizens' jury who perhaps were excluded from that option? Perhaps the legislation as supported, or the approach as supported. Were there any groups that would have been excluded from the conclusions that were drawn?
In terms of who wouldn't be eligible,
yes.
In terms of adults, well, there was a capacity requirement.
Mm-hmm.
So in a similar way to the way that other jurisdictions with permissive regimes have a requirement of capacity, that was also...
So that sounds to me as though it's quite a broad, quite an open approach, perhaps broader than most jurisdictions around the world. And people were going into that very consciously, perhaps thinking that it's significantly broader, perhaps, than Oregon and other places.
Certainly, the approach that the jury voted for is certainly more broad than Oregon, and is really similar to the approaches in the Netherlands and Canada.
So other than perhaps going down the under 18 route, there wouldn't be such a question from the evidence you saw over that kind of moving or expanding the range of people included?
Well, that wasn't something that the jury were asked to consider, so they were limited to the questions about whether they thought in principle it should be lawful, and if so, who for, and children were not part of that conversation.
Thank you.
Okay, thank you. Paul Bristow.
Thank you, Chair. First question to Professor Nancy Preston from Lancaster University, my old university. So, welcome. Do you think there's enough data available about access to and the provision of palliative care and end-of-life care in England and Wales?
I mean, I think we know there's not enough, and there won't be enough until it's part of the National Health Service and it's got full funding. I mean, it's 75% funded from tombolas and things like that. What we have got in the UK is much greater access for more people with different conditions. So I do a lot of work in Europe. It's mainly still for people with cancer, whereas in the UK it's expanded to, people with COPD, heart failure, motor neuron disease. It's a much broader church, although people most commonly think of it as for people with cancer. But we're having to develop services largely for those people in the community funded outside of the health service, which limits its reach.
How do you feel if we had a much more focused and universal palliative care system? How do you think that would influence the debate around assisted dying and suicide?
I think if you look at the Oregon case in particular, Linda Ganzini, who did a lot of the work in the States looking at it, she used to refer to Oregon man. An Oregon man doesn't want to be a burden. Oregon man was hunting, shooting, fishing, and kind of wants to make his own choices towards the end of life. So these are decisions people are making, regardless of the care they're going to receive. So it's not necessarily always about poor provision of palliative care. It can be about people wanting control, and that's what you hear a lot in the debate, in the discussion, with patients and their families.
And how would you react to the evidence we heard earlier about burden and control? Because would you accept that there is a would you accept that there's a feeling that to be how do I put this in the most dignified way? We heard evidence earlier from people saying that those with disabilities and those who had lost control, that their life, certainly from Baroness, I think Finlay, was saying that they didn't feel like it was a burden. I mean, everyone's experiences are different. Do you feel there's a fear of that burden, that there's contagion, that people will begin to feel that they are a burden, or is that not weighed by the evidence?
We've got no evidence to support that would happen. I think just what we do commonly hear is about people wanting to remain as independent for as long as they can. I guess the concern is that could apply to people with disabilities and other groups, and then they can feel disenfranchised in the decisions they're making, and then it gets back to coercion and control. There's nothing in our evidence to say anything about that, really.
Okay, thank you very much.
Okay, thanks, Paul. Right, Paulette Hamilton.
Oh, thank you. Good morning, both. Could I start with yourself, Professor Preston? I asked the question to the first panel, and I'm going to ask the question again. I'm hoping you were in the room at the time, but it was about the fact that there is a taboo around people talking about death and dying. It was around the fact that 64% of people think that we don't talk about death enough. And the question I asked the first panel, and I'm really interested because of all the brilliant work you've done, is are patients and their families given enough opportunity and support to discuss death and dying?
I think if I give you an example of a large study we did across Europe, we had 1,100 patients, and we were talking about advanced care planning. So what's the kind of care you would want to receive at the end of your life? And towards the end of your life, you may lose competency. So you need to have talked to someone, you need to share those decisions in advance. Most of the people who came on the study probably had a median survival of 12 weeks. This was a really important conversation. When the doctors tried to introduce it, half of the patients said, I don't want to go there, I'm in a good place right now, which meant they hadn't had that conversation. And then half of the ones who said they did want to, the families said, well, actually, they're in a really good place right now. So we're trying to train people to have those conversations better. We've got free online resources. And one of my drivers I'm using is the ambulance service, because if we don't have those conversations, and it might feel like you don't want to upset someone and it's not a good time, the paramedic turns up and they're facing a family they've never met before, having a really difficult conversation in a very acute moment. So we do need to be better about it. And we know that we can make that better. We did it during COVID in care homes, and we trained up the care home staff to have those conversations, and families, and the families responded incredibly positively to it.
Thank you for that. I'm going to ask you the next question, but again, I'm going to focus the next question on you because it's around doctors, and the question is around. Let me start by saying I had the absolute pleasure, myself and the committee, a number of us here, of going to Oregon, and it really opened my eyes to this subject. But one thing that I found out while we were there, large numbers of doctors didn't want to be part of it, and I think it was highlighted earlier that only 2% of the doctors from Oregon actually wanted to take part in anything around assisted dying. Now, the question I have is, how does the legislation of assisted dying impact on care practitioners, so nurses, doctors and others, and what support would they be given to take on this massive role?
Yeah, and I think it depends on the jurisdiction. So in the Netherlands, where we did research there, the doctors are very supported within the process. But even though they're very supported, it can be, well, one of the quotes we got was, it's stressful killing somebody. But that was somebody who carried on doing that. But they would maybe sometimes, some people feel okay with it. Some people feel, I can manage 1 or 2 a year. Other people say, I can't be involved. And in the can't be involved, when we did research in Switzerland, they may not even feel able to say, well, there is a right to die association you can talk to. I might not be able to have that conversation. And so there's real gradients of their level of involvement and the impact it can have on them. And the Swiss system, I think we don't really talk about a lot, but they promote it as almost a civil system, where it's been contracted out to the Right to Die associations, because like in a lot of countries, assisted dying doesn't happen in hospitals. It predominantly happens in people's homes. In the Netherlands, it's care homes, hospices. So the Swiss model is very much that it's outside of the system of the main healthcare system. With volunteer doctors, this is their sort of passion and drive, and so it's taken out of mainstream health, which has removed some of the pressure on the doctors within the health service in Switzerland.
So do you feel that this country is anywhere near equipped to do anything like that?
I don't know if doctors in this country really know what it would feel like to do it. I don't think anybody does until you're faced with it. And as I said, there'll be a range of responses as to whether they feel able. And I think Baroness Finlay mentioned that in the BMA report, although there's a lot of support for it, and I think that's in part reflects people thinking, well, maybe I need it myself. But I don't think I could do it myself.
Right, interesting point. Now, could I bring you in, Dr. Is it Mullock?
Yes.
Oh, fantastic. We've had, as a committee, we've had evidence from all over the world, especially the ones that have been highlighted, Belgium, Oregon, there's one more, Netherlands. We've had information come to the committee, and they have expressed concerns about the Association of Palliative Medicine have expressed concerns about people reporting information around the issue of assisted dying and medication. And while we were in Oregon, the thing that got to me was the reporting of things. I'm not going to say was a little bit slapdash, because I feel that's trivializing it, but I felt that we could have had an Harold Shipman and they wouldn't have known, because it's just very database, matter of fact, after it all happened. And I'm not sure how much of that was really checked. So the information is, do you feel the quality of information reported from other jurisdictions like Oregon, Belgium, Netherlands, relating to assisted suicide, assisted dying, is actually good enough?
That's a really difficult question to answer, and I can't actually answer it, but I could sort of point you to the work of some people who have done appraisals of the monitoring systems that have been put in place. One example is Professor Penny Lewis, who's actually now a law commissioner, has done some work on this. And her assessment is actually that the monitoring that's carried out is actually quite robust and sound, particularly perhaps in the Netherlands. And if I remember correctly, I think over a sort of 10-year period, 111 examples of possible breaches of the Dutch criteria were reported to prosecutors. That led to one prosecution and an acquittal. It's really not possible because it relies on honest reporting. So, potentially there are problems and flaws in that approach, but like so many things, it's really difficult to assess how robust that monitoring is.
So thank you for that. So my final question, Chair, with all the research you've done around this area, what are your views? Do you think it is possible? You're smiling at me, I like that. What do you think? Do you think it's possible to get honest reporting on this in this area?
I think it's challenging, and I think in the Netherlands, I think they have a very sort of clear reporting system. But there is an anonymous survey that is carried out, I think it's every other year or every year, by the team at Erasmus, and they find that doctors closer to the end of life are more likely to use what they call palliative sedation, so a larger dose of sedation rather than going through the euthanasia legislation. But it's an anonymous survey, it's difficult to interpret and understand, but it doesn't mean they're doing euthanasia, but they're reliant on going to large doses of drugs to sedate people. We're doing a big study at the moment on sedation across Europe and trying to understand practice, and within palliative care it's very much titrated, proportional, according to the patient need. But what happens, but more so in maybe GP practices, things like that, it can be used in different ways, so that would be outside of the current legislation.
Excellent point to stop. Thank you, Chair. Absolutely brilliant. Thank you, ladies.
James Morris.
Thank you, Chair. One of the challenges that we have on this inquiry is, obviously this is a very emotive subject which can polarise views, but it is in what is the nature of the evidence base that this committee is actually looking at, because if we make a policy change, it needs to be on a robust basis of evidence. So I just was going to ask each of you, probably starting with Dr. Richards, about what you thought the critical pieces of evidence that this committee should be looking at as it deliberates on this matter. Maybe one critical piece of evidence that you think is absolutely central to our deliberations. Dr. Richards?
From what I've heard today, you're covering a lot of the big issues. One critical piece of evidence, I suppose, thinking about the arguments for and against that have been rehearsed in the House of Commons and the House of Lords for many decades now, I suppose the big piece of evidence is whether there's abuse and whether vulnerable people are coming within the scope of any legislation in any jurisdiction. So that would be kind of the number one thing for me, I think.
And just on that point, do you think there is robust evidence about that particular issue to do with abuse? Does that exist as a body of evidence in a coherent place?
I think it's clear to say there is no robust evidence that there is abuse, as Professor Preston has said today already. However, it is a hard thing to research as well, I would say.
Okay. Dr. Mollock, what's the critical evidence this committee should be looking at if it was persuaded to change the law or look at this issue differently to the current regime?
I think probably the evidence from Oregon, which you obviously have already explored on your visit. I think that's really critical because the Oregon approach is the approach that's proposed under the recent bills, which is a sort of quite restrictive approach where only terminally ill people are eligible. And so if you compare the evidence coming out of Oregon, where the numbers have remained quite low and there is no evidence of abuse, although there also have been reports of perhaps some worrying examples of people with depression who are not adequately assessed, compared to the evidence coming out of the Netherlands, which has a much more permissive approach, where the numbers of people choosing to die by euthanasia have grown quite a lot. And I think it's about 4% of everyone who dies in the Netherlands dies by assisted dying.
I'll just ask you one question, sorry to interrupt, about Oregon. When we were in Oregon, a claim was made that the introduction of assisted dying had, quote, improved palliative care in Oregon. Do you have any perspective on that, or whether you think that's a credible claim?
Well, I think it's certainly credible because, I mean, in a sense, although they are very, very sort of intertwined, they're also separate issues. And if a jurisdiction makes a determined effort to improve palliative care, then I think that it's perfectly possible for palliative care to improve at the same time as legalising some form of assisted dying.
Professor Preston, what do you think of the critical evidence base this committee should be considering?
I think you should consider all the evidence, and I think it's definitely a decision for parliamentarians to come to. But if you were to change the law, I would really recommend you look at the impact on healthcare workers and the families and ensure that they are looked after as well, because the debate often is very focused on the patient and the patient right, and I think we need to make sure everybody involved in this is supported and looked after.
Mm-hmm. Okay, thank you, Chair.
Fascinating. I think it's Paul Blomfield next.
Thanks very much, Chair. I think we established wherever you are in this discussion in the first session that everybody wants to see the very best palliative care, but even the best palliative care can't avoid a bad death for some people. Would you agree with that? And let me start with Dr. Richards.
Yes, I would agree with that. And it depends how you define what a bad death is, because as was discussed in the previous session, this isn't just about pain and symptom management. This is about autonomy, and it's about dependency, and it's about people's identity, because how people die is seen to sometimes represent something about who they are, to say something about who they are. So I think it's really important that we don't just think it's about pain and symptom management, although it is in some cases. So a bad death for some people is not dying on their own terms.
Thanks very much. I don't know whether Professor Preston, you'd like to add to that at all?
I mean, I think if we, as Naomi says, if we're talking about physical symptoms, I think you can, on the whole, try and treat those, and it is through sedation. So it does mean that you would be losing consciousness early, in a similar way maybe you would be having an assisted death early. But I think Naomi's absolutely right. For some people it's not about that. It's about continence. It's about mobility. It's about being able to make decisions for yourself. And that's, for the classic example would be someone with, say, spinal cord compression, and they know what is going to happen in the future, and they think, I don't want to be like that. And it could take a long time before they died, but that's not where they want to be. So I think it's a mixture of both. A lot of the stuff we can manage with sedation, but how people feel about themselves is different.
Thanks. Obviously the debate that's taken place in various jurisdictions has kind of landed with two routes. And one is about assisted dying laws for those with terminal illness. Other countries have gone further in relation to unbearable suffering. There's an argument that if we change the law in relation to terminal illness, which is where the debate is in this country, there's an inevitability of a slippery slope into widening the law. Is there any evidence of that from jurisdictions which have taken the route of terminal illness? Dr. Mullock?
No, I don't think there is. Oregon has had the same approach that hasn't expanded for, quite a long time now. I think there is evidence that if you begin with an approach that allows it for unbearable suffering caused by a severe physical condition, then it's quite hard to maintain a sort of intellectually convincing or clinical distinction between a physical illness that causes unbearable suffering and a psychiatric illness that causes unbearable suffering. But I think that problem is removed if you have an approach of terminal illness, because then it becomes about allowing people to control an imminent death rather than cutting many years off their lives.
Thank you. I don't know whether, Dr. Richards, you have any views on that issue?
Yes, I would agree with Dr. Mullock that there is no inevitable expansion, as we can see from the Oregon model, which is the model across states of the US. It's yet to be seen what will happen in Australia, New Zealand, other places that have legalized more recently, and whether they will expand. I think it's also a question of how we frame this expansion and whether we see, the population are perhaps deciding that, they may legalize for a certain group, a certain category of person, and there may be widespread support for that. And then other people with other kinds of illnesses, suffering, also want to have access to that mode of dying. And so it's not, the expansion is because it's publicly demanded. And the other reason why you might have changes of criteria is because they've seen, from practical experience, they've seen what works and what doesn't work, and they're tweaking their system. It's not necessarily to be categorized as a sort of a negative slippery slope. So that's just my addition. I would like to say something else about the previous question. Is that allowed?
Yes, of course.
Sorry, just with a bit of time to think. I think this issue of bad deaths and suffering at the end of life is extremely important. And in the previous session, there was a lot of discussion about a case study of anorexia, which is really not what we're talking about here. There's 600,000 people that die annually in this country. We're talking about the meaning of dying, and that's really important that we stay focused. I think there's a lack of knowledge about how many people, what suffering entails at the end of life. I just think we have a kind of absence of knowledge, and palliative care professionals deal with people who are at the end of life in their day-to-day practice, and they see that and experience that, and they help people with their suffering. But we have to ask if they are professionally inclined to sort of to look at the extent of suffering, if it's going to reflect badly on their what they can offer patients, or what is out with what they can offer their patients. I just, as a researcher, I feel that there is a real lack of evidence about the extent of suffering at the end of life, which leaves a void. So, for example, Dignity in Dying, one of their campaign angles is to say that there is all this unmitigated suffering. And then you get palliative care organizations saying it's not true. And honestly, we don't know. And I do think this is quite important, actually, because it's not right to say that, people don't need to fear dying. We can say it, but maybe they do. If we don't have the evidence, then maybe they do need to fear dying. So I just wanted to make that point. Thanks.
Okay, thanks very much. Can I ask one last very niche question to Dr. Mullock, which is, from your experience of being involved in the citizens' jury process in Jersey, do you think that's a helpful way of engaging in this debate? And do you think it's a good process in terms of taking things forward?
I do think it's a very good process, and a really good way to, have democratic participation. I think if you're going to have a citizens' jury, or indeed a referendum, you can almost be sure that they will vote to legalise assisted dying. We've seen that. I think the results are very soon to be out in France from their citizens' jury, but the early vote suggested that I think it was something like 75% were in favour of it. That's what happened in Jersey. In New Zealand, the referendum was, I think, 65% of the population were in favour of physician-assisted suicide for the terminally ill. So if you accept that that's almost certainly going to be the result, and you're prepared to go forward on that basis, then I think it is very useful.
Thank you.
Thank you. Rachel Maskell next.
Thank you. I think what's come out today is the importance of having information to make informed choices. And but there are things that we don't talk about and we don't gather information about, and therefore those choices are all the more difficult. And I think we've already heard about the reluctance of talking about death. I think there's another area of taboo, and it certainly came out in the Oregon data around dignity and talking about continence as being an issue, whereas many, many people have to live with incontinence. In fact, far more people than we probably realise do, and that shouldn't be an issue where people are fearful of. However, in gathering evidence, it does seem that we have got a shortfall in evidence that could be helpful in decision making, and I'm therefore quite interested in digging into some of this. So, first of all, Dr. Richards, bearing in mind your speciality of looking around older people as well as others, in the light that we heard in the earlier session that 1 in 5, 1 in 6 experience elder abuse, what is the evidence around people that have sought, say, to go to Switzerland from the UK, or people that are requesting assisted suicide, assisted death, that have been coerced or have, as a result of perhaps emotional, financial, other forms of abuse?
So the evidence for people going to Switzerland?
Yeah, as an example, yeah.
Yes. There is none. That they have been coerced.
Okay.
No, there is none.
Is that evidence actually gathered as to the reasons why, and is that explored?
Well, there's been interviews with researchers, with relatives who and friends who return. There's been interviews by police before the DPP changed its guidance. There was evidence the relatives accompaniers were interviewed by police. So I think there has been some scrutiny, and there's no evidence that we know of.
Okay, and that's my big concern, is about evidence that we know of and being able to drill down into, are we asking the right questions around this to protect the most vulnerable?
Yeah, I mean, the idea that someone it's quite a tricky process to get to Switzerland. And, the Right to Die organisations have their own, it's not just a free-for-all over there, it's a regulated process over there. So you've got all of the barriers with travelling and the huge bureaucratic barriers of applying from the UK, then sort of going there, and then bureaucratic barriers, administrative barriers, procedural barriers at the other end. So, it would take a seriously committed person who was trying to coerce a relative. This is really not the question for me. It would be much more about what happens when it's lawful in your own country rather than...
Well, clearly that how you frame the legislation could well depend on a kind of other experiences to know about that process.
I can speak about Swiss
UK.
Citizens.
Yep, please.
We've done interviews with people who've from Dignitas largely who've gone to Switzerland, and Naomi's right that you have to be very determined to do that. I don't think there's any evidence of coercion with them. But in Switzerland, again, most people it isn't. It's their own choice. It's a very private decision. It's very quiet. But we've had cases where, not many, very few, but where the family introduced the idea. And another case where the treating physician had prescribed and was happy to prescribe, but felt the patient then lacked competency, so couldn't have the drugs, and the Right to Die Association was going forward, and she stopped the procedure. So I think, I think, as we've said, is any system possible to have every safeguard in place? I think it's going to be very challenging, no matter what. But you are always going to get some cases, aren't you?
Thank you for that. Could I also ask about the quality of death as well, and what evidence there is on the number of deaths where people have not had what I'm classifying as difficult deaths, where people have either been in pain at the end of death or had a very uncomfortable death. Do we know what the data is on the numbers that we're talking about there?
That's not an area of my research to look at.
Does anyone hold that information either? No? Okay. And finally, I just want to ask about the scrutiny of the data in different jurisdictions as well. And one of the things that I think concerned many of us when in Oregon was some of the data that was being held by their equivalent of Department of Health. For instance, they didn't scrutinise the process of people dying. They didn't put it on death certificates, the reason for death. And one of the statements that stuck in my mind was when the civil servants said that it took 10 people took more than 6 hours to die in Oregon. When looking at the data, how are you verifying the veracity of that data to ensure that the right questions are being recorded, the right factors are being recorded in order to analyse the real impact of somebody's death experience in those jurisdictions? In your research, anything? Okay, so that shows further evidence of a lack of information. Okay, thank you.
Interesting in itself. Lucy, Alan.
Thank you. I wonder if I could ask Dr. Richards a question about some of the research that you've undertaken in jurisdictions where assisted dying is lawful, around the coexistence of palliative care and assisted dying, how that works together. Does it impact on the quality of palliative care? I think we heard earlier that somehow it was detrimental to palliative care. Can you have assisted dying and palliative care as coexisting successfully?
Okay, I'm glad you asked me this question. I just want to say in response to the previous question, I don't really look at monitoring. However, I would say there's a lot of jurisdictions that have, passed legislation which all have different monitoring systems. So if you don't like the Oregon monitoring system, then look to the Australian monitoring system. The law in Victoria State, Australia, is sort of considered the strictest and most conservative in the world, and I'm sure they've got quite a developed monitoring system. So, that's something that is potentially remediable. So, in terms of the question about the relationship, so there's what we discovered was across the jurisdictions that have legalized, there's very little research conducted. I think we had about 16 studies that came in our scoping review of the literature, and it's varied and contested across different jurisdictions. So all the way from Belgium, where it's considered sort of integral and synergistic, it was assisted dying was kind of proposed by palliative care in that, so they were behind the legislation, to, places where it's Switzerland, where again, it's kind of the civil model. So palliative care professionals kind of aren't really trained in how to deal with requests, to Oregon, where it's just quite variable. In some institutions it works alongside. Some institutions conscientiously object, so institutional sort of conscientious objection in that case. But what's really interesting since our scoping review in 2019 is that there's really interesting literature coming through from Australia and from Canada now. And I think while palliative care organizations would like, they still maintain it, palliative care organizations, umbrella organizations in jurisdictions that have legalized will maintain their opposition. That this kind of fundamental principle of to neither hasten nor postpone death is a kind of operating principle. But but yet it's sort of in many cases down to the individual professionals to decide whether they want to be involved or not, because it's a legal right. And so there's all of these kind of grey areas, and what palliative care professionals specifically are having to face is, it's now unavoidable that they will be asked by their patients, will you help me? They've got a legal right to ask, and they've got a legal duty to refer if they don't want to be involved themselves. So they're in an interactional space now where they are dealing with these requests. But it's not true to say that all palliative care providers are conscientiously objecting. That's just not the case. And sometimes, it's causing deep reflection, negotiation of values, responsibilities and relationships, and, self-examination of, maybe what motivates you to be in palliative care in the first place. But some people are embracing, some people are continuing to conscientiously object. It's a whole variety, it's a spectrum. So it's certainly not kind of this master narrative of incompatibility. I was at a meeting last week, the Palliative Care Organisation of Canada was saying, assisted dying is an existential threat to palliative care, but it's just not the case, because palliative care continues to operate and thrive in jurisdictions where it's been legalized. So it's just, I think if we'd done that systematic review of the literature and found a whole load of evidence then of sort of a panic and a sort of deterioration of palliative care, the evidence would be there. I think, so I'll stop there, sorry.
That's very helpful, thank you very much. Dr. Mullock, I wonder if I could ask you to comment on what Lord Faulkner told us this morning about the current UK, England law on this area. He said it's a mess. I just wondered if, with your legal background, whether you could comment on your views on whether it is a mess.
Yes, I do agree with Lord Faulkner. I think you asked Rachel before about any evidence of coercion in relation to people travelling to Switzerland, and there is no evidence. And what happens is the police investigate following the return of the family member or friend who's assisted the person who's died, and there have been no prosecutions. Of course, that doesn't mean they necessarily shouldn't have been, but insofar as a retrospective investigation after the person who's died is no longer here, it's very difficult to actually establish, what motivated those assisting, etc. And so I think Lord Faulkner was right. I think at the moment people feel abandoned and very frightened. They may seek an assisted death abroad. It's also very expensive, as well as this sort of bureaucratic burden. And the enormous effort to arrange that. It costs, I think, something along the lines of £10,000. So for many people, they just couldn't afford to take that route. So they might otherwise, choose to take their own life by suicide in the jurisdiction, usually without help in circumstances, that can be very, very difficult or distressing. They might fail. And so at the moment, although you could argue, as I'm sure Baroness Finlay and Baroness Hollins would, that, people are prevented and so they're saved by the ban, in reality, not everybody is saved. Some people who are vulnerable will go to Switzerland. Others who are very vulnerable will die by suicide. And then other people will just simply, have to face the natural death that's coming for them, and in circumstances that might be, very, very difficult.
And in terms of, from the medical perspective, is there a lack of clarity, if you're a medical professional, in terms of how you respond to a patient who is requesting assistance?
Well, the General Medical Council has produced guidance, ethical guidance, to help clinicians to sort of find the balance between talking to patients and helping patients, but not encouraging or assisting them towards suicide. So I think there is some guidance there, but it's incredibly difficult for for healthcare professionals to navigate that. And also very difficult, I guess, in terms of in the palliative care context where a person might be asking for, a hastened death, and the fears that have come about in recent years, partly as a result, I guess, of Harold Shipman, but the way that area of care has been scrutinised, for example, with the Liverpool care pathway, clinicians, I think, are probably very worried about stepping over the line.
Thanks, Lucy. And then just finally from me, I started the session today by asking the four peers about their lived experience and their personal reasons. And why do you care so much? I asked them. Obviously, many of us have experienced deaths of people close to them. And Professor Peston, you've spoken about the least researched and perhaps poorly understood area is how families experience death when there's an assisted death or a hastened death is involved, as opposed to the normal course of life, the normal life course. I just wondered what your obviously we've seen what you've sent us in written evidence on this, but I just wondered if giving oral evidence, what your reflections are on that dynamic.
Yeah, and I think it's complex. So I think for the families, in some ways it's easier because they know they can care for the person and they know when the end date is going to be. So it gives a bit of it holds it. Because often when you're waiting for someone to die, that can be quite difficult because you don't know when that's going to happen.
Yes.
On the other side, there's the secrecy. So normally when you're going through something like that, a death in a home, in a family, you'd be talking to everybody about it, you'd be sharing, you'd be getting support. And because often people, and I'm talking particularly the Swiss data, they don't want other people to have these conversations with them. So this is really hard work, isn't it, to have these conversations, and you're already in quite a difficult place. So they hold it with one or two people. So the person who's enabling and helping is actually on their own quite badly in this. And after the death, there is secrecy and taboo, so they may not even tell the family what had happened, or they may tell the family, and then the rest of the family say, why did no one talk to me about this? I feel disenfranchised from it. And I think that's why we need to make sure that we have a system where families are involved. And, families in the UK from Dignitas would rarely go to a hospice for bereavement support because they'd be very concerned about being investigated.
Yeah. And then just finally, maybe Dr. Mullock, you may wish to offer some thoughts on this with respect to, when you're involved in Jersey and the citizens' jury. Ultimately, we can talk about the mechanics of this. We can talk about palliative care. We can talk about the drugs involved. We can talk about the family's responses. But there's a Rubicon to be crossed here before we get into all of that, which is effectively the moral argument, which is, do we believe that we should involve ourselves in people's deaths? And I just wondered what your reflections were on that, being involved in Jersey, and any research that you've done around that.
Yes, so I was quite surprised, just very quickly if I say, I was quite surprised by the outcome of the citizens' jury in Jersey, because they had many hours of very balanced evidence, looking at evidence from campaigners, evidence from religious groups, evidence from doctors. They heard evidence about the law in lawful jurisdictions, and I was very surprised actually that they decided that they wanted to take quite a permissive liberal approach, based on the concerns that they've heard. That's not my position. I feel quite worried about what's happened in some places like Canada and the Netherlands. In terms of my research, I did a PhD on assisted dying as part of a project on the impact of the criminal law and healthcare ethics and practice many years ago, and that sort of started this area being one of my areas of research. And so I've looked at sort of human rights arguments in the key cases such as Nicholson. I've looked at conscientious objection and the way that the law could protect healthcare professionals from being sort of compelled. And then more recently I've looked at conceptions of vulnerability to assisted dying. And so I think the approach taken in Oregon, New Zealand and Victoria is probably provides a compromise between a sort of liberal approach in which there are dangers to people who are not necessarily going to die soon anyway. And so that's why I think it ought to be limited to terminally ill people.
Yeah. Okay, well, thank you so much for giving evidence. So that's Dr. Richards down the line, Dr. Mullock and Professor Preston in the room. Thank you very much. Sorry we've slightly overran, but I really appreciate your candour and your time. Thank you for giving evidence this morning. Order.
The proceeding has ended. 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 The proceeding has ended.